So I'm going to break this really into looking at three areas where we are in relation to sort of the macro climate. So all our research at the moment that we're doing is on the nursing workforce. The majority of research is looking at the nursing workforce in Ireland. So we've developed a model for safe staffing in medical surgical areas that has been rolled out by the HSE. And we have just finished emergency departments, and we hope to publish that report later in the year. I know the World of Irish Nursing had a piece in it this month about the research we did in emergency departments, and we've started to do some work in the nursing home section. But in relation to looking at the work of clinical placement coordinators and the vital role they do in student support, we can't really look at the work of CPCs without looking at the context within CPCs are working in. So we can see that really over a 20-year period, the vast majority of countries within the OECD have increased the number of nursing graduates. So the OECD average per 100,000 population is 43.6. Ireland hasn't. Ireland is one of the few countries that has remained relatively steady in the number of graduates. So we produce 28.9 nursing graduates per 100,000 population. We'll see in the next figures that that's going to increase. They will need to increase the number of nursing graduates coming out of universities and institutes of technology in Ireland for a number of reasons, and I'll come to those in a moment. But we've had a relatively steady number of graduates, but what we're going to see, I would predict over the next 5 to 10 years is an increase in graduates to meet the increasing demographic changes that we're going to see in relation to an aging population, in relation to people with long-term illness and so on. One of the issues in Ireland at the moment is that we're playing catch-up, and there's a really good paper published by Williams and Thomas which looked at the impact of the reduction in staffing during the austerity years. And in some ways, what we had is we had a moratorium on recruitment, and the vast majority of you here will remember this. And this was followed by targeted voluntary early retirement scheme. And this led to a number of posts being lost within healthcare in Ireland. And this led to a pay bill being reduced by 11%. But I'll show you figures in the moment, and it will show you the impact that it had on frontline. But what happened is, as the workforce, the permanent workforce fell, the agency numbers increased during this time. So the loss of the workforce was just replaced by agency. And even though the pay bill was cut by 11%, in real terms, the saving was only 3.4%, so a minimal saving on the pay bill. So basically, there was a 6.5% cut to pay rates and a 7.2% fall in human resource numbers. But really, the cuts didn't lead to savings within the system. But this figure here is really important, and CPCs working within the clinical area will notice this. Even though during the austerity years 28 to 2014, therapists such as physios and OT increased by 17.4%, and nurse specialists increased by 53%. Now, nurse specialists are a really, really small number overall. But if you can see, I know it's a little bit difficult there, but if you see staff nurses, which are the main group that provide frontline work, frontline care to patients, they decreased by 10.7%. So we had a massive decrease in the frontline workforce. And nurse management, those at clinical nurse manager level, ADON level as well, also decreased by 10.4%. And the consequences of this was that the years where the community workforce was building, there was a swap. Most of the job losses were lost within the community setting. And if we look at 2008, we had more staff working in the non-acute sector. We had approximately 54,000 healthcare staff working in the community sector. That's all healthcare staff. And there were 52 working in the acute sector. But then by 2014, this had flipped. we'd now more staff working in the acute sector and fewer staff working in the community sector. And this means at the moment now we're playing catch up to try and increase the number of staff working in community, but also to replace the number of staff nurses that we lost within the system. So what has this got to do with CPCs, and what has it got to do with nursing? Well, it means that we're going to have to educate more nurses, more nursing students, and we're going to have to educate them in a different way. We're going to have to put a huge emphasis on community, and this will be driven by sláinte care. So this is going to impact on the role of CPCs in the future. Basically, what happened during the austerity years is that we lost a lot of corporate knowledge. We lost a lot of people who knew how the health system ran because of early retirement and because of job losses. And this can lead to long-term damage within a system and exacerbates issues in the future. The other issue we have is that our older population is growing rapidly. So the proportion of older people over 65 is going to increase from 13.3%. Our last census in Ireland was 2016. So that's about 450,000 people, but it's going to increase to 18.5% in 2031. So that's in 10 years. So this will lead to an overall increase of 58.7% of older persons. So from we'll approximately have around 1 million people aged over 65 in 2031. And again, this is going to have an impact on the provision of healthcare, the education of nursing, and the development of roles within community, long-term residential settings, and so on. The biggest increase will be in those aged 85 years of age and older. And the numbers here are due to almost double, from approximately 67,000 people aged 85 years of age and older in 2016 to nearly 133,000 by 2031. And the reason for that is that proportion of people within society requires the highest levels of healthcare. So the CSO, what the CSO is saying is that our projections in Ireland, we're going to have a 12% growth in the overall population over the next 10 years, a 59% growth in the 95 years of age and older, 59% in 65 older, and then 95% in the 85 population and older. And this will impact on a significant additional demand for health services. And why is that? The vast majority of older people live very healthy, disease and disability-free lives. But those people over 65 who do require health services, we have a higher proportion of those using the health services. So at the moment, people aged 65 years of age and older, as we said, account for 13% of the population, but they require 1/3 of healthcare activity. So they're only 13% of the population, but they require 33% of healthcare activity. In 10 years' time, they're going to be 95% of the population, and they will account for 50% of healthcare activity. The main workforce that is going to be providing care for those older people will be the nursing workforce, along with our healthcare assistant colleagues. But again, this has implications for how we educate and prepare our nursing workforce. However, we have a problem. As our populations age, the potential supply of labour in the economy is declining. So sorry, I think I might have muted myself there. A number of us are getting older, but there are a few of us to look out to provide care within the future. So if we look at, on average, across the OECD, at the moment, the OECD defines people of working age between the age of 15 and 64. So at the moment, there's more than 4 people of working age for every person aged over 65 and older in 2012. So that's wonderful. That's all people of working age, not just people working in healthcare. But over the next 40 years, the rate is projected to halve. So from 4.2 in 2012 to 2.1. And this is going to have implications for the recruitment and retention of staff working within healthcare, and particularly in nursing, which is the largest group of healthcare providers within the system. So what do we need in the future? And again, this is going to impact on how clinical placement coordinators provide care and support students within this system. So to meet within the next 10 years, we're going to need a 48% increase in the primary care workforce. And this is from the Health Services Capacity Review from the Department of Health itself. There's going to be a 43% increase in long-term residential care beds. So we'll need to increase our long-term care beds by 10,000. And approximately 1 in 5 people over the age of 85 requires long-term care. And there will be a 120% increase in home care. So central to this will be nurses in relation to it. So if we look at what's going to happen, GP appointment visits will increase from 18.9 million to 26.2 million. So GP practice nurse appointments are going to increase by 40%. So GP practice nurses are going to be extremely important, and there's going to be growth in this area. Public health nursing and community nursing is going to increase by 46%. And then allied health, physio, OTs, and so on will also increase. So we can see there's going to be a huge shift from provision of acute care into non-acute services within community. And you can see there, so a 39% growth in GPs, we need a 40% growth in public, in practice nurses, we need a 46% growth in public health nurses, and then 38% growth in physio, 32% growth in OTs, and so on. So nursing in the community is going to be a particular area for increase within the next decade. In preparing for this, I came across a really good review which was published this year by Ryan and McAllister, and they gave a really good framework for what's going on in relation to clinical facilitation, they call it. They emphasize clinical facilitation, but they do cite the work that I did a number of years ago in relation to that. And what we can see is that roles similar to clinical placement coordinators have developed internationally over the last decade, but the terminology is very different. Mentor, coach, facilitator, supervisor, clinical teacher, practice education facilitator, and clinical placement coordinators. But what we have is what Ryan McAllister broke the themes in the literature that have been published, excuse me, over the last 20 years into 3 areas: the challenges, best practice, and professional development. And these were really the themes that I was thinking of talking today. So I'm going to base a little bit on the work of Ryan and McAllister, but also the work that we're looking at in relation to the projections over the next decade for nursing students and the support they will need. Angela highlighted the number of challenges in her presentation earlier on. And there are 3 groups of challenges that have been identified for nurses providing and midwives providing support to students while on clinical placement, increasingly supporting students under stress. And it was interesting to see the figures for the provision of pastoral care. Role confusion, which is still there, it's still, and we can talk a little bit about the tension between those. And then the preparedness for the role and how people are supported in undertaking the role. So they were the 3 themes that Ryan and McAllister came out, and they were very similar to what we've seen in the research we did 20 years ago. So increasingly, clinical placement coordinators and clinical facilitators are seeing increasing mental health challenges among students, increasing levels of stress, anxiety, and dealing with students under stress. This is very much when students are working in high pressure clinical environments. All you need to do is try and compare a ward now from 10 years ago, and you'll see wards are very, very different environments than they were 10 years ago. Patients that would have been nursed or cared for in intensive care units are now cared for within the ward environment. And the other thing about the clinical environments, and you notice this from which students are working in, Ireland has the highest bed occupancy rates in the world. We have 97% bed occupancy rates. The OECD average is 75%. And they recommend that bed occupancy rate should not go above 85%. So we're doing, on the safe staffing research, we found bed occupancy rates on wards of 110, 115%. That's not to say you had 2 patients in the bed at the same time, but it was that there was huge turnover of patients and the wards are never empty. So this has pressures for students, and you see that in relation to it. The other thing that Ireland has some of the fewest beds in the world for its population, 3 beds per 1,000 population, and this has an impact on the pressure that emergency departments are under. So you're working in that environment with students. So in Ireland, we're working under high pressure clinical environments. The other thing that comes up is bullying is an issue. Students being part of a team and integrating in a team because they're there on placement. Attitudes and behaviors of students, different generations have different ways of looking at it. The move from hospital-based schools of nursing into universities has had changes in how students perceive their education and training. Big issue of working with students who are failing comes up for clinical facilitators, and then students not acknowledging difficulties they have. So these are the main challenges and stress for supporting students within the clinical area that comes up in the literature. The other challenge, and Angela highlighted it very well, and it was very much part of the study we did 20 years ago, is the role confusion. And where does this come from? And it comes from a number of areas. It's what the literature says and what studies find, it's the undervaluing of the educational aspect of the CPC role. I remember when I did the evaluation, and it was really strange, and I was interviewing CPCs at the time, and they did everything but try not to mention the word teaching, because for some reason the word teaching seemed to be a word that people didn't want to be used at the time, because I think it was outlined in the job description at the time that CPCs were not clinical teachers, but teaching is a very central aspect of the role and a very important of the role, as it is for all nurses and midwives in their role. So we made a recommendation within the report around teaching, but it's a very important aspect. Another reason in the literature for lack of clear role identity is the tension and divided loyalties between the academic side and the clinical side, so what students are taught and that theory practice gap, and then what goes on within the clinical area. And then the tensions between providing education and clinical care. And it was very interesting to see the number of CPCs that were brought into clinical care during the COVID-19 pandemic. Tensions and the perception of higher education institutions to the CPC role. And there is a need then in relation to a lot of studies have identified that clinical facilitators, clinical placement coordinators, clinical mentors are sometimes omitted from academic conversations or omitted from academic planning. And there's a need to explain the uniqueness of the role to others, and the preparation of the role is important and acknowledged as the role challenges emerge. So where does the challenges around role confusion come from? I would say it's that tension between theory and practice. It's that tension where CPCs have a foot in the education side, but they also have a foot in the practicalities and the reality of clinical work. The other challenges that come up, and we found this in our study and it's still there, is preparation for the role, is looking at appropriate preparation, with that, again, tension between those who are seen as expert clinicians and being brought into the role, but then being prepared for the teaching aspect of the role. So that clinical teaching element of it. Professional development while in the role. The literature still says that professional development focusing on those who provide clinical support to students is not widespread, although there are innovative approaches emerging. And then some evidence that preparation for the role is inadequate. Now, in the study we found, when we did it 20 years ago, we found that the preparation was good in the evaluation, but it'd be interesting to see what it's like now. The second theme that comes up in the literature is best practice and CPCs working within it, and three areas within that: meeting role expectations, facilitating education, pedagogy and facilitation, and then advancing the discipline. And this is the real challenge, is highlighting the discipline of what clinical placement coordinators and those who facilitate student clinical experience do. So those working in roles similar to CPCs have been described as linchpin because they play a key role in facilitating student learning, linking classroom knowledge with clinical experiences. This is where the main one comes through. There's a lot of time spent negotiating and preparing students within placement. Negotiation becomes a big aspect of the role. And there is a number of activities and expectations that have grown over time. And Angela's slide of all the different roles that CPCs do really captured that a lot better than I could in relation to looking at the literature. Angela really captured how the roles have grown: pastoral care, role module, clinical teacher, assessor, leader, and so on. Those working in roles in CPC in relation to best practice in education have been found to use the following types of learning approaches: reciprocal learning, peripheral learning, inquiring questions, reflective practice, debriefing, intrinsic skills, assessors, and others. So reciprocal learning is where the students and the CPCs share knowledge with students, and they learn from each other. Peripheral learning, this is where CPCs prepare them on the periphery and then give them confidence to take on further responsibility as they provide increased patient care. So the CPCs are that role that bring the student to the periphery before plunging them straight in. Inquiring questions, CPCs are very much involved in developing critical thinking and critical reasoning within their role through the questioning of students. And then reflective practice, which look at developing students' reflection on action and inaction, which is seen as a very central part of the role. Debriefing, this is seen as a really important role of CPCs, where they take designated time away from the clinical area to assist students to learn, to debrief, to talk about their experiences within a safe environment. And then intrinsic skills that CPCs utilize to experience. So being curious, CPCs are very much self-directed in their role, very creative and flexible, and then being involved in assessing clinical learning, and then other approaches that have been identified that roles such as CPCs use as solution-focused learning, transformative learning, balancing didactic and facilitative approaches. So that paper by Ryan Magazine really nails it, I think, in relation to the and drawing on all the literature that's been published over the last 20 years in this area. And they call it pedagogy and facilitation, which I think is really good. The third aspect where CPCs are very much involved in advancing their discipline is they're very much placed to enact cultural changes and to inform the nursing curricula. And this is a big area of CPCs, informing the nursing curricula, because they are at the cutting edge of clinical practice and practice changes. So if you look at the history of nursing moving into the higher education sector, what happened is nurses who were involved in academia moved further away from the bedside, and CPCs were vital in taking up that aspect of providing support to students at the bedside within the front line. But again, this leads to questions about the further development of the role in the future. So the other areas coming up in relation to clinical facilitators and CPC roles is they bring active involvement in changing practice, evaluation of the experience of students. They encourage students to be agents of change by translating knowledge into practice, and they share their insights of what they learned in the classroom within the clinical area. And so three themes have come up in the literature around a knowledge translator, so bringing what the students have learned within the academic setting, advising the curricula, and a change agent both in practice and changing how the curriculum is developed. Unfortunately, there's not a lot in the literature around professional development. It's a big gap. It's a big gap, and Ryan McAllister, who did the review, found very little. They identified 9 studies in relation to which roles similar to CPCs support and advance their practice role. But what they found was professional development wasn't fully available because of time pressures, type of role, and another issue was absence of clear understanding, that role confusion in relation to it. So things like that came up that they did find there's an overall theme of looking at theme-based education, looking at the educational priorities when developing that, enhancing skills, educational leadership, and those professional development activities that lead to outcomes. If we look at those that come up, are things like clinical skills updates, working within virtual communities such as this. This is a very much an example. This forum for CPCs is a virtual community. Simulation-based education, incorporating evidence into practice, student well-being, curriculum development, data management, academic outcomes. So where are we going in the future? So what's going to happen? Well, we need joint academic appointments. We need to develop these further. These need to be developed at all levels in relation to it. Mobile technology and telehealth is going to become increasingly important, and we learned that through the pandemic, and Angela highlighted that in her presentation very well. There needs to be developments in assessing student competence that move away from looking at tick box exercise into a more encompassing aspect of students' care. The enhanced practice contract is going to lead to changes in preparing nursing students for how they work. And of course, Sláinte care is going to be a very central aspect of what we do in relation to it, that Sláinte care is going to be driving really over the next decade the provision of care, moving them from acute-based services into non-acute services and community services. Because of Sláinte care, there's going to be an increase in community placements. There is need to look at the amount of time that students spend in the community, the extent of those placements in the community, and then the roles of CPCs within that. Around about 18 years ago, there was a pilot CPC in the community project, which I evaluated, and I have the report there that at the time, but that wasn't really extended. Now, the CPC role in the community was found to be very different within the acute services, but there are a number of recommendations that I made in that report. I did it for the Department of Health about 18 years ago. But certainly as students move more and more into the community, and as there's that bridge between acute and community services, between midwifery services in hospital-based and midwifery services in the community, there's going to be a need to look at the support that students require in relation to that. Interprofessional collaboration is going to grow. We know now that patient care is very much a team-based activity between nursing, midwifery, medical, allied and social healthcare professional staff, and so on. And CPCs will have a big role in preparing students to work in those teams. Digital health, data analytics, we can see only too well how dependent we've become on IT systems and the importance of them, and looking at data analytics is going to be important. Increasing diversity both within the provision of care we provide the population that we provide care to, but also our student cohort, looking at different pathways into nursing, looking at colleagues from overseas who provide a large proportion of care to our population, as well as looking at what we call non-traditional students, encouraging mature students to come into nursing and midwifery. The social determinants of health is going to be really important, and this is going to drive nursing curriculum in the future, caring for individuals with complex health and social needs, so not just looking at the health, but looking at the social needs. A big emphasis on mental health is going to be really important, and our psychiatric nurse colleagues will be very important in relation to looking at mental health needs of people within acute care as well, in acute medical and surgical settings, as mental health issues become to the fore. Preparing nurses to understand policy, healthcare policy, and how healthcare policy impacts on health outcomes. The curriculum is going to look at epidemiology more and biostatistics, and we've seen that during the pandemic, how epidemiology and biostatistics, how to assess and intervene to improve the health and well-being of populations, preventative rather than curative. Health equity is going to become extremely important within. We know that a lot of health issues that occur, both physical, psychological, social, are due to inequities in society. Interprofessional team building for improving population health. The economics of healthcare is going to be extremely important. We just had a paper published last week from our research team on what a nurse-sensitive adverse event costs the health service and how much a nurse-sensitive adverse event leads to a length of stay. So if you get your staffing wrong, your nurse-sensitive adverse events, such as hospital-acquired pneumonias, urinary tract infections, and so on, go up, and we can now, for the first time in Ireland, cost them. That was published in the Journal of Advanced Nursing, and it's important that we have that economic data. Systems thinking is going to become very much part of the curriculum, the ability to understand complex demands, develop solutions, and manage change at micro and macro system levels. So it's going to be a very different curriculum over the next decade that we're going to be looking at. And then simulation-based education, and CPCs have a big role in that, in relation to that. As I said, disease prevention, experiential collaborative learning, integrated curriculum, and evaluation and recommendations. To finish, I had a quick look at, well, I didn't have a quick look, but I know the report well, but I looked at the 2000 report. There's the publication in Journal of Advanced Nursing from 2002, I think, but the actual report was written in 2000. And the actual report was a big volume of work. But these were the recommendations at the time, and the role was relatively new. Remember that, it was a relatively new role. And the research was funded by the Department of Health and the HRB at the time. And the thing was that the idea was whether they were to continue the role. And it was looking at the job description to be reviewed during rostered placements. Again, there was nurse tutors in the development of student competencies that CPCs had to be centrally involved with college lecturers. Evaluation of the clinical placement role as part of overall education quality improvement system. And there is a need to evaluate the whole area of student support again. That's really needed, and the central role of CPC in that. Preparation, there were a number of recommendations around preparation, and a lot of them have come up: interpersonal skills, reflective practice, teaching and assessing, evidence and research-based evidence, pastoral care, creating learning environment, and professional development. That was 20 years ago. They're still coming up. The same issues are still coming up today. Preparation program, be eligible for academic recognition, credits for the program. Progression at the time, CNM2 was to be at the post, but again, there's been a lot of developments over the last 20 years. Education needs an association as a professional support group. So progression within the posts, I know from Angela's presentation, is a big issue. Reporting structures, entry requirements, the teaching role, the stipulation that CPCs are not clinical teachers be removed from the job description. This is to make provision for the teaching role of all professional nurses. to be involved in the preparation of student nurses for practice placements. This meant that relationship between the university at the time, pastoral care was there, external placements, and the role of CPCs there, student assessment and practice development, and having a very important role in relation to practice development. So that's where we are, and it's interesting to see whether there have been a number of changes over the years, where some things have changed, but then where other things haven't. So Angela, I'm happy, I think we might have a couple of minutes for questions or any aspects of it. So I think to sum up, in many ways the role has added, what I can see is it's added a number of really important elements, but in other ways there are still a lot of questions in relation to professional development, in relation to the advancement of the role, the relationship between higher education institutes, and the definition of the role. And I think that comes from the tension between the academic side of things and the practice side of things. So thank you.